Hello everyone, myself Dr. Parth Goswami, and today I am going to teach you a important topic from the blood banking, that is a blood transfusion reaction. See friends, blood is also one of the drug, right? Following intake of any drug, you can have the reaction in your body. Some people can have vomiting, some people can have headache, or maybe life-threatening lethal effect, right? So as like that of medicine, as like that of drug, the blood transfusion patient also can show some of the reactions. So we will discuss the blood transfusion reactions in the detail in this today's topic of discussion. So what is our learning objective for today's lecture? It comes under competency number 22.6, right? So our objective is to understand the all blood transfusion reaction. Then I will teach you which are the investigation that can be done for a case of blood transfusion reactions. And finally, we will see some of the management of blood transfusion reaction if it happens. Alright. So what do you mean by blood transfusion reaction? So the blood transfusion reaction, which is formally known by the name BTR, right? It is the adverse effect that will occur during or after the blood transfusion. Here the blood transfusion means a transfusion of whole blood, transfusion of red blood cell, right? Transfusion of platelet, etc. like that of blood components. So it is the adverse effect that will occur during or after the blood transfusion. And such blood transfusion reactions can be mild. Mild means it can be like that of fever, you can have vomiting, right? So that can be considered some of the mild moderate transfusion reaction, but sometimes it can be lethal. If you develop coagulopathy, then patient can undergo disseminated intravascular coagulation and death also can occur. So the effect can be mild to lethal. And so you can prevent some of the blood transfusion reaction while some cannot be prevented at all. So blood transfusion should be given judiciously, and it should be given whenever needed, right? Because transfusion reactions are there. So basically there are 12 type of blood transfusion reactions. Which are the 12 types? The first one is immediate immune hemolytic transfusion reaction. Second one is non-immune immediate hemolytic transfusion reaction. Third one is febrile non-hemolytic transfusion reaction. Fourth one is allergic reaction, then anaphylactic reaction, then circulatory overload, then delayed hemolytic reaction, then platelet incompatibility, then iron overload, then TRELI, then graft versus host disease, and finally transfusion transmitted infections. So these are the 12 type of adverse reaction, and we will see each adverse reaction in the detail one by one. Alright, this lecture will be somewhat lengthy, so listen it carefully. It will take a time for explaining me a whole transfusion reaction. So the first blood transfusion reaction is IHTR, that is immediate immune hemolytic transfusion reaction. Here the name itself suggests immediate means it will occur within 24 hours of blood transfusion, right? Within 24 hours it will happen. Here the immune word means the underlying cause for its occurrence is transfusion of immunologically incompatible blood, right? Suppose you have given the immunologically incompatible blood to the patient, then such reaction is happen, and that's why the word immune is used. And hemolysis means obviously destruction of red blood cell. So here you will have the hemolysis of your RBC, and you have the sign and symptom mainly because of this hemolytic reaction, right? So you might have questioned that when such immunologically incompatible blood transfusion happen, why we give such blood? So it can happen when you have done the mistake in blood grouping, or you have not done a cross match, means indirect Coombs test. Suppose ICT and blood grouping compatibility is not checked between the donor and patient, then such immediate immune hemolytic reaction can happen. Alright. And Suppose such immunologically incompatible blood is given, then the responsible antibodies for the development of hemolysis are obviously anti-A, anti-B, Cal, JKA or FYB, right? So this type of reaction happen because of transfusion of immunologically incompatible blood, and so the responsible antibodies will lyse the red blood cell. And such hemolysis can be of two type. There can be two mechanism for the development of immune hemolytic transfusion reaction. Either it can be extravascular, that is occur outside the blood vessel, or it is intravascular hemolysis which will occur within the blood vessel. So you can have two mechanism for its development. So we will understand this particular immunological incompatibility in the image form. I have prepared this master chart. So let's understand. Suppose you have the patient with A blood group, right? And this patient need a blood. Now this patient will have corresponding antibody B in its blood. You know very well that the A blood group patient will have antibody B. So suppose you have given incorrect blood to this patient. You have given the B blood group blood to this patient. So what will happen? The donor is having B blood group, not A. So they will have corresponding antigen B within their blood, right? So this antigen B and this antibody B will react with each other and they will form the antigen antibody complex. So you will have the development of antigen antibody complex because of false blood group, or because of not done, because of because if you have not done indirect cum test. So if the false blood is given, or if the cross match means indirect cum test is not done, then antigen antibody complex can develop, right? And once this complex is developed, there can be activation of complement, and because of complement activation you can have intravascular hemolysis, means destruction of red blood cell within the blood vessel. And so you can imagine that within the blood vessel, the lysed red blood cell will release the hemoglobin and its trauma in the circulation, and from the circulation they will go into the kidney, and so you will have a blood in the urine, you will have the hemoglobin urea in the intravascular hemolysis. But suppose the complement system is not activated, right, then you will have the hemolysis in the spleen or liver, which is known by the name extravascular hemolysis, in which you will not have hemoglobin urea. All right. Now, what could be the etiology for development of such immune hemolytic transfusion reaction? So, obviously, you are not going to give wrong blood to your patient, right? You will definitely do a blood group. You will do a cross matching, that is indirect cum test. But the mistake can happen if you have the clerical or technical error. Means what? The clerical error include, suppose you have done a mistake in a blood bag labeling. The label is false. Suppose the patient identity is written incorrectly by a technician. Then also such type of reaction can happen because you are giving the wrong blood because of clerical error, right? So you can issue a wrong blood because of clerical error. So always be careful in writing the patient identity, particularly name, registration number, etc. All right. Second mistake can be technical error. Means you have done the mistake while doing the blood grouping or cross matching. If you are in a hurry and you have not done blood grouping or indirect cum test correctly, then it is come under technical error, right? So you might have done mistake in grouping or cross matching. Such type of mistake can happen if you are not trained, right? Or if you have not done cross match by a ideal way, you are just doing a saline cross match. And if you have not done ideal cross match, then immunologically incompatible blood can be issued. So you might have not identified the weak antibody, right? If you will not do ideal cross match, then you cannot identify the weak antibody. That's why it is advisable to do always a blood grouping and ideal indirect comb test, that is cross match. All right. Now, the because of development of antigen antibody complex, we have already seen that you will have the complement activation. But apart from complement activation, this complex can induce certain other response as well, like that of neuroendocrine response, then coagulation effects, then cytokine effects. These four response can occur in our body: neuroendocrine, complement activation, coagulation effect, and cytokine effects. All right. Now I will teach you a clinical feature of such immune hemolytic transfusion reaction. So as we have discussed, because of antigen antibody complex, you can have cytokine effect. So particularly you will have a release of interleukin 1 and tumor necrosis factor because of such complex development. So you can have fever. This interleukin 1 and tumor necrosis factor can induce a fever. So the patient can have fever, right? Patient can have chills and rigors. And patient also can have the pain at transfusion site or in the chest or in the back, and that can be because of release of such cytokines. All right. We have already discussed that there can be complement activation. So because of complement activation, you can have hemolysis, and because of hemolysis, you can have blood in the urine. And if you lose the blood because of hemolysis, then your blood pressure can fall, and the patient can undergo low blood pressure. So patient can have hypotension, and because of hypotension, patient can complain dizziness, like that of symptoms. All right. Now suppose we have seen that because of complement activation you will have hemolysis, and so you will have fall in blood pressure. Because of cytokine release you will have the fever, like that of symptom. But suppose the coagulation system if activated because of this complex formation, then guys, you will have the multi-organ dysfunction, particularly if the patient undergoes disseminated intravascular coagulation. It's a very rare adverse effect, but it can occur. So if the DIC is developed because of immunologically incompatible blood is given, then you will have the multiple clots which will affect your multiple system, especially if your more than two system is involved, then it is known by the name multi-organ dysfunction. And if you develop the multi-organ dysfunction, then liver, kidney especially involved in this MOD. And because of the kidney involvement, you will have the shutdown of your urine formation. So you will have oliguria and anuria, and because of which the metabolic waste product will get accumulate, and so it can be lethal for your body. Patient can undergo shock as well. All right. So this was all about the immune hemolytic transfusion reaction. So that was about the first adverse transfusion reaction, which is very important, right? Now we will see the second transfusion reaction, that is a non-immune immediate hemolytic transfusion reaction. Here the name itself suggests that the etiology, the underlying cause for the development is not immune, it is a non-immune reaction. So there are basically five causes for the development of non-immune immediate hemolytic transfusion reaction: bacterial contamination, then thermal exposure, then mechanical hemolysis, chemical effect, or hyperkalemia. I will teach you every cause one by one. So the first one is bacterial contamination of blood, which can do the hemolysis of your red blood cell. See, basically almost whole blood, red blood cell, all the blood components usually stored in a cold temperature, that is 2 to 6 degree, right? The exception is platelet. The platelet blood products is stored at 20 to 24 degree. Otherwise, all the blood products usually stored at a cold atmosphere. So as you are doing the blood storage in cold atmosphere, bacteria usually cannot grow in the cold temperature. The bacteria need a 22-degree temperature, room temperature. But bacterial contamination can occur if the particular bacteria that can grow in the cold temperature as well. So such bacteria are E. coli, then Yersinia enterocolitica, and Pseudomonas. These three bacteria can grow in the cold temperature as well. But still, you might have questioned that why bacterial contamination occur in the blood, why it will occur while doing the blood collection. So it can happen if you have not properly cleaned the phlebotomy site, if you have not taken aseptic precaution, then you can have bacterial contamination. So always clean your collection site properly with the antiseptic solution. Otherwise bacterial contamination can occur, and the bacterial contamination is common in platelet because the platelets stored at 20 to 24 degree, which will provide a favorable atmosphere for the bacteria for the contamination and the growth. So that is the bacterial contamination of blood. All right. The second cause for the non-immune immediate hemolytic transfusion reaction is mechanical hemolysis. Why mechanical destruction happen? Suppose you are in a very hurry, right? The patient is, you have the traumatic patient, right? Patient have multiple fracture, and you need to transfuse the blood immediately to raise the blood pressure. And if you are transfusing the blood bag by compressing, if you are compressing the blood bag for immediately giving the blood to the patient, so if infusion is done under the pressure by compressing the blood bag, then mechanical hemolysis can occur. So never compress the blood bag for blood transfusion, right? If you have used the blood pumps for the transfusion, then also mechanical hemolysis can occur. Third cause for such non-immune IHDR is thermal hemolysis. Suppose the blood is stored at below -3 degree, or it is warmed at more than 42 degree centigrade, then chances of hemolysis is more. So be sure that your blood is stored at 2 to 8 degree, not more than 42, or not less than -3 degree centigrade. All right. Fourth cause of non-immune IHDR is chemical hemolysis. When chemical hemolysis will happen? Suppose you have injected hypotonic saline or 5% glucose along with the blood transfusion, then it can hemolyze the blood, right? So never give hypotonic saline or 5% glucose along with blood. Suppose in the IV sheet you are giving the blood as well as the drug, so the drug can hemolyze the blood. So don't give both the substance together in the same IV set, and never ever inject the drug into the blood bag. Never do such practice. Any drug should not be injected in blood bag, right? They should be given separately. All right. And the fifth cause of non-immune IHDR is hyperkalemia. The hyperkalemia can lead to arrhythmia of your heart, right? The main etiology for the development of hyperkalemia is massive transfusion. Suppose a multiple blood transfusion is given, then more potassium can be released in the blood, which can lead to hyperkalemia. All right. So this was all about the non-immune immediate hemolytic transfusion reaction. Both these immune and non-immune IHDR are immediate hemolytic transfusion reaction, right? All right. What is the clinical feature of such non-immune IHDR? So the clinical feature are same like that of fever, muscle pain, hypotension, etc. because of hemolysis or cytokine release. But additionally, here patient can have abdominal pain and vomiting, which is commonly observed, right? And if the multi-organ dysfunction occurs, then patient can have DIC, oliguria, and the shock. All right. How will you prevent such immediate hemolytic transfusion reaction? How will you prevent? So see, for the prevention of such reaction, you need to give only compatible blood. You have to give the same blood group. Donor and patient blood group should be same, and you have to do the indirect Coombs test before blood transfusion. So the blood group should be matched, and cross matching, that is indirect comb test, also should be done. Before issuing a blood to the patient, you have to check for hemolysis or bacterial contamination. Try to avoid the clerical or technical error, right? For that you need to give a training to the staff. And for preventing a bacterial contamination, always take aseptic precaution during the phlebotomy. So that are some of the preventive measures for preventing the IHTRs. Now you might have question, how will you check for hemolysis of red blood cell? How will you check it? By seeing the blood bag, can you say that it is hemolyzed or not? So yes, you can check it by inspecting the blood bag and attached tube. If both blood bag and the attached tube show a purple color change, then obviously it is a hemolysis, right? But if you have the purple color change only in the blood bag, not in the tube, only in the blood bag, then it is bacterial contamination. So you can differentiate a hemolysis and the bacterial contamination by just observing a blood bag and attached tube. All right. Now, how will you investigate a case of blood transfusion reaction? How will you investigate? Which are the laboratory investigations? So first of all, whenever the physician is telling you that patient is having blood transfusion reaction, immediately stop the transfusion, right? Instruct him that immediately stop the transfusion, and you have to check that whether any clerical or technical error happening or not. You have to check for clerical and technical error. If it is okay, then you have to check for hemolysis or bacterial contamination of the blood bag. It can be easily checked by observing the color change in the blood bag or attached tube, right? Suppose this is also okay, then you have to repeat the blood group and the indirect comb test, that is cross match, both with the patient and donor, right? Patient and donors blood group should be checked, and you have to do a cross match indirect comb test. All right. Additionally, patient's direct comb test also can be done to check for irregular antibodies. If DCT of the patient is positive, then obviously the cause is immune hemolytic transfusion reaction, means immune reaction is occurring. If immune reaction has occurred, then obviously your DCT of the blood will be positive. Patient DCT will be positive. All right. Now suppose you are suspecting bacterial contamination as a cause. So to check for the bacterial contamination, you can do a blood culture as well. So send the blood back for the blood culture, right? You have to check the kidney function as well. For that you need a serum from which urea, creatinine and bilirubin estimation can be done. If your kidney is not functioning properly, then your urea and creatinine will be elevated. And suppose you have the hemolysis, then your bilirubin will be increased. So for the kidney, you need to do urea creatinine, and to check for hemolysis, you need to investigate with bilirubin. In the hemolysis, the bilirubin will be raised. All right. Urine also sent for urine also should be sent to the pathology laboratory for urine examination. In the urine examination, you will check for presence of hemoglobin, bile salts, bile pigments, and the urobilinogen. If hemolysis is there, then you will have the increased hemoglobin in the urine. You will have increased urobilinogen as well in the urine, right? So for that, urine examination should be done, and you have to take care that first voided urine should be sent for analysis. All right. And now for doing such investigation, you need a blood sample, right? So the urine is collected in a sterile container. Blood bag will be sent to the laboratory for the blood culture, right? But for doing the urea, creatinine, bilirubin, and for doing the blood grouping and cross match, right, you need a sample. So you need to collect a blood in a plain vacuum. So we will collect the blood in a two plain vacuum in which you can separate a serum, right? The one vacuum is to be sent to the biochemistry laboratory for such urea, creatinine and bilirubin estimation, and from the other second vacuum you need to do a indirect Coombs test and repeat reverse blood group, right? So the sample should be collected in two plain vacuum. All right. Now, how will you treat such immediate hemolytic transfusion reaction? So obviously, stop the transfusion, check for clerical technical error, and find out the underlying cause for development of IHDR. Then you will give the normal saline. If the blood pressure is falling, then dopamine is to be given. Suppose you don't have urine output because of multi-organ dysfunction, then diuretic drug might be needed. And suppose the bacterial contamination is the underlying cause, then antibiotics is needed to combat the bacterial infection. All right. Now, third transfusion reaction is FNHDR, that is febrile non-hemolytic transfusion reaction. The name itself suggests here you don't have hemolysis of red blood cell. In the previous two transfusion reaction, we have the hemolysis of red blood cell, but here you don't have any hemolysis. Here you only have the fever. Febrile means fever. Now how the fever develop, that we will see, right? So here you will have the fever. Fever means you will have the greater than 1 degree increase of your temperature above the baseline temperature, right? You will have the 99-degree fever mainly, 99 or 100 degree. And it will occur within 24 hours. It is an immediate reaction. You will have the chills and rigor as well. And there will be no complete medical explanation for development of such FNHDR. And usually it's a self-limiting, right? You don't need to worry if only fever is there. And it can be seen in the multi-transfused patient, particularly thalassemia major patient, in which the blood transfusion is to be given repeatedly, or in the aplastic anemia, in which the patient need blood at every 20 days, right? 20 to 30 days. So in the multi-transfused patient, such reactions will be developed. Why? What is the pathogenesis? So here is the pathogenesis. The febrile non-hemolytic transfusion reaction is because of development of antibody against the donor leukocyte antigen. See, while doing the blood transfusion, we are doing the blood grouping and indirect Coombs test, but HLA matching might not be done. The HLA antigen is different in every individual. So the patient can develop antibody against the HLA antigen of donor, and so antigen antibody complex can develop and it can activate the cytokine so that the interleukin 1 is released and it will lead to fever. The second cause for the development of FNHDR is that if you have stored the blood for the long time, then there can be accumulation of the cytokine within it, and the cytokine activation obviously will lead to release of interleukin 1 tumor necrosis factor like that of pyrogen, and so you will have the fever. Alright, how will you manage the FNHDR? You don't need to worry, just give the antipyretic medication. Simple paracetamol will be effective, but before labeling it as a FNHDR, always check for hemolysis. And antihistaminic drug intramuscular injection is given if the patient is having more fever, right? If there is a sign of inflammation, then antihistaminic drug can be given. To prevent the subsequent FNHDR in the multi-transfused patient, right? Suppose for the first time such reaction occurred, then if the patient come against after 20 days for blood transfusion, particularly thalassemia major like patient, then at that time prefer leukocyte reduced product. You know, in the red blood cell, you can reduce the leukocyte by doing the filtration or by preparing it in a special type of instrument, right? You can remove the buffy coat from the blood. So you can in such way you can reduce the leukocyte in the red blood cell, and prefer to give leukocyte reduced red blood cell if the patient is having repeatedly having the fever after the transfusion. So leukoreduced red blood cell is the solution for this transfusion reaction. Underlying cause for the development of FNHDR is leukocyte. That's why leukoreduced production can minimize the side effect, this particular side effect. All right. Now, fourth transfusion reaction is allergic reaction. The name itself suggests you will have the allergic symptom. Why such reaction happen? What is the pathogenesis? So here is the pathogenesis. See, suppose the donor plasma is having the allergen protein in their plasma, right? And the patient IgE antibody will react to such allergen. So this particular reaction is occurring because of plasma transfusion, especially if you are giving a transfusion of fresh frozen plasma or the poor plasma, right? So if the plasma blood component transfusion is given, then allergic reaction can occur. Now this IgE will react with the allergen, and so the IgE, right, attached to the mast cell and basophil. And because of this reaction, the IgE can degranulate, can destruct such mast cell and basophil, can activate such two allergic cell, mast cell and basophil. So they will release their content. What is the main content of mast cell and basophil? Yes. So the main content is histamine. So the histamine will be released from the mast cell and basophil because of IgE activation by binding to the allergen. And so because of histamine release, you will have the allergic reaction. Now, which are the allergic reactions? So the allergic reactions are obviously a redness, then itching, then hives, urticaria, and sometimes it can be laryngeal edema as well. These all effects are because of histamine release. Patient can have itching, patient can have such red rash, right? Patient can have hives, which is known by the name urticaria. Alright, how will you manage the case of allergic reaction? What is the management? So obviously here the pathogenesis is only histamine release. So you have to give the drug which will block the effect of histamine. So such drug is antihistaminic drug. So suppose the patient is only having the rash or the hive, and you are giving the antihistaminic drug which will relieve the symptom, right? So if the symptom relieved within 30 minutes, then you can again restart the transfusion. But if there is a severe reaction, then sometimes steroid might be needed, and in such case you cannot again start the transfusion. You know, the steroid is more potent anti-inflammatory drug than the antihistaminic drug. So if this drug is not working, then steroid has to be given. And suppose the patient is repeatedly having such reaction. Suppose the patient is giving previous history that in the past I have given the plasma and I have the allergic reaction. So in such scenario, antihistaminic prophylaxis can be given before initiation of blood transfusion. Alright. And what is the second mode of management of such allergic reaction? So the another option is that you can give the blood product without plasma, right? The saline washed red blood cell can be given when it is appropriate. Suppose if the patient is patient needs only red blood cell, then you can give saline washed red blood cell to prevent the allergic plasma reaction, right? So that was about the allergic reaction. Now the fifth transfusion reaction is anaphylactic reaction. The name itself suggests that it is an anaphylactic reaction, which is a very severe form of allergy. This is again also occurring because of plasma transfusion, but the cause is different. See, this is the immediate hypersensitivity reaction of your immune system. It is a type 1 hypersensitivity, right? It's a dangerous allergic reaction. It will occur immediately after giving a few ml of plasma or the plasma containing blood product, and it is a very rare side effect. Now why it is happening? What is the pathogenesis? So the underlying pathogenesis for the development is IgA deficiency, right? It will occur in patient who have the IgA deficiency. Suppose in such patient you have given the blood transfusion, then patient will develop IgA antibodies. Patient will sensitize for the first time. Such sensitization can occur because of pregnancy as well, right? So whenever you are giving the blood for the second time, the patient is already having the formed antibody and they will react tremendously to that antigen. So the IgA deficiency is the main underlying cause for the development of anaphylactic reaction. And such reaction happen because the patient have sensitization from the transfusion or pregnancy, and because of sensitization they have developed anti-IgA antibody, and so in the second transfusion they will react with the antigen tremendously, and so you will have the severe allergic anaphylactic reaction. The sign and symptom is, because of laryngeal edema you will have the cough and difficult breathing, nausea, vomiting, diarrhea can occur. As far as the cardiovascular system is concerned, you can have the fall in the blood pressure, arrhythmia, or the syncope. All that is because of type 1 hypersensitivity. And you can have the urticaria, flushing like that of allergic symptom as well. What is the management? Obviously, if the patient is having anaphylactic reaction history, then don't give plasma. Plasma deficient product is always preferred if patient is giving history of anaphylactic reaction. If blood pressure is falling down, then epinephrine injection can be helpful. To combat with allergic reaction, antihistaminic drug or steroid can be given. And if the patient respiratory system is involved because of laryngeal edema, patient is having difficult breathing, then oxygen has to be given, and sometimes the patient need an endotracheal intubation as well to assist the respiration. So that is about the management. And in such scenario, to prevent such reaction for the second time, it is preferred to give a saline wash red blood cell or IgA deficient plasma. If the patient doesn't need plasma and patient need RCC only, then always give saline wash red blood cell in which plasma is removed. And suppose the patient doesn't need RCC but patient needs plasma only, and if it is necessary to give the plasma, then always prefer IgA deficient plasma to prevent such anaphylactic reaction. Sixth transfusion reaction is transfusion related acute lung injury, that is TRALI. Now in the TRALI, what happened? The donor or patient plasma will form an antibody against the leukocyte of patient, right? Sorry, they will develop the antibody against the leukocyte that is present in the pulmonary microvasculature. And such antibody will react with the leukocyte in the pulmonary microvasculature, and they will develop a leukocyte emboli. And you can have the complement activation, histamine release, or prostaglandin release as well, because of which you will have the inflammation and you will have the increased capillary permeability of your pulmonary microvasculature. You will have the increased permeability of your pulmonary capillary, and because of which you will have more exudation of fluid in the lung, and you will develop finally a pulmonary edema in the trachea. So this is an example of non-cardiogenic, means the cardiac cause is not there, non-cardiogenic pulmonary edema. So you will have the fluid collection within the alveoli of your lung, and that is because of inflammation induced by such leukocyte emboli. Alright. Because of pulmonary edema, because of fluid collection in the lung alveoli will not function properly. So obviously you can imagine that you will have the problem in your respiration. So the patient complaint will be respiratory distress, dyspnea mainly. Sometimes fever and cyanosis also can be seen because of histamine release or complement activation, or because of pyrogen release. Alright. If you do the chest x-ray of such patient, then you will have the bilateral pulmonary infiltrate, right? That is because of fluid collection in the alveoli. Now what is the treatment of such adverse effect? This is a rare adverse effect, but if it occurred, then what is the treatment? The treatment is obviously to assist the respiration. You have to do the supportive care for respiratory insufficiency. Suppose the patient oxygen level is falling down, then you have to give oxygen therapy. Still, if oxygen therapy is not helpful via nasal cannula, then sometimes you might need endotracheal intubation. And in the severe case where the intubation or nasal cannula or face mask oxygen not working, you might need ventilation as well, right? Usually in most of the case the pulmonary insufficiency reverse in 10 to 12 hours after the supportive therapy. Alright. Now, seventh adverse transfusion reaction is circulatory overload. Such adverse reaction occur if you have the overload of the blood. When such scenario happen, so it will happen when too much blood is transfused and the patient cannot tolerate the volume of such increased blood. Right? You have given the too much blood. So you can have congestive cardiac failure, because of which you will develop pulmonary edema, and so you will have the respiratory distress. So here the underlying cause is congestive cardiac failure by excessive blood. Now, who are the risk factor? Who are at more risk for development of cardiac failure? So the cardiac failure usually occurs after massive blood transfusion. If you have given too much blood, and the high risk persons are old age, very young age, and if the patient is already having congestive cardiac failure in the past, and the normovolumic person, in such scenario the patient is at high risk for circulatory overload. And because of pulmonary edema, you will have the respiratory symptoms. You will have the respiratory distress, right? The patient mainly have respiratory distress. And sometimes cyanosis, hypertension and tachycardia also can be seen. So you will have the sign and symptom of congestive cardiac failure. The patient can have edema over the leg as well because of CCF. The management is you have to stop the transfusion immediately. And to combat with circulatory overload, IV diuretic can be given, which will help in relieving the symptom of CCF and which will treat the circulatory overload as well. To assist the respiratory distress, you have to give oxygen therapy, right? And sometime for the circulatory overload, phlebotomy might be needed. As far as the preventive measure is concerned, it is always preferred don't give too much blood and give the infusion rate at 1 ml per kg per hour over the 3 hour, right? The blood transfusion should be given slowly over the 3 to 4 hour. And it is always preferred to give a red blood cell instead of whole blood to prevent this particular adverse effect. Alright. The eighth adverse effect is delayed hemolytic transfusion reaction. This particular reaction will happen after 24 hours. The name itself suggests delayed means it will occur after 24 hours. And the hemolytic reactions means you will have the destruction of red blood cell. And here the responsible cause is irregular antibodies like that of RH, Cal, Duffy, Kid, etc. Right? Usually we are screening, we are not doing the antibody screening while doing the cross matching, right? But it always advisable that if you have the facility in your blood bank, then irregular antibodies should be checked. See, basically there are two main blood group system, that is ABO and RH. So we are checking ABO RH compatibility only and we are doing the cross matching. But sometime the minor blood group system, particularly Cal, Kid, Duffy and Kid, also can be responsible for carried out the hemolytic reaction. So the here alloimmunization will occur because of this minor blood group system. So it's advisable if in your blood bank facility is there, then screen for these minor blood groups as well. Check the antibody against this minor blood group as well before giving blood to the patient. Alright. And obviously because of hemolysis, you will have the reactions like that of fall in the hemoglobin. You will have the hemoglobin urea, means presence of hemoglobin in the urine, like that of symptom, right? Alright. The ninth adverse reaction is platelet incompatibility. Here the name itself suggests this reaction occur because of platelet transfusion. In the platelet transfusion, usually usually same blood group platelet is not given, right? So here you can have incompatibility sometime, although it is a rare, but platelet incompatibility transfusion reaction can happen. Why? So see friends, usually it's a amnestic response in a patient who is previously transfused by platelet, right? Particularly in the multiparous woman in whom the previously platelet transfusion is given. And in this patient, usually such platelet incompatibility occurs. Here the responsible factor is antibody, obviously, and you will develop the alloantibody against your platelet A1 antigen, and this anti-platelet A1 antigen will destruct the platelet. They will do the non-specific destruction of all the platelets, and because of destruction of platelet you will have the adverse reaction. So what can be the clinical feature because of platelet destruction? So you will have the fever, chills, you can have the respiratory distress in the form of dyspnea, or because of low platelet you can develop purpura over your skin as well. You know, whenever the platelet is low, over the skin purpura will develop. How will you manage the platelet incompatibility? So for the management, see, platelet transfusion will not help, right? Because the underlying cause is development of antibody against the platelet. So you cannot give the platelet transfusion. To subside the inflammation, you can give steroid. And the main mode of management is to remove the responsible antibody. This antibody has to be removed, which is present in plasma. So it can be removed by doing the plasmapheresis, in which the plasma is removed, right? Or you can give immunoglobulin intravenously to neutralize this antibody. So IV immunoglobulin also can be given. These two are the main mode of management: plasmapheresis and IV immunoglobulin. All right. Now 10th adverse transfuse reaction is graft versus host disease. Now this particular reaction will happen when the patient is immunodeficient, right? The patient immunity is low and you are giving a blood to the such patient. Then what happen? The donor's lymphocyte will engraft and will multiply in the immunodeficient recipient, and that will react against the host tissue because the patient is immunodeficient, right? All right. Now, who are at the risk for development of this adverse reaction? So obviously the risk is high who is immunodeficient. So the immunodeficiency, immunity can be low when you have the diabetes, when you are having certain malignancies, particularly hematological malignancies, right? Or you have any cancer. The reaction can also happen if your lymphocytes count is low, if your bone marrow is suppressed, or the newborn is receiving the exchange transfusion. So these are the high risk patients. All right. How will you manage these type of adverse reactions? So obviously, first of all, prevention is by the pre-transfusion irradiation of the all blood components that contain the lymphocytes. Right? You know very well that reaction is because of donor lymphocytes. So you can remove the lymphocyte, you can remove the white blood cells by pre-transfusion irradiations. So that will be useful. All right. Steroid can be given to reduce the inflammation, or immunosuppressant drug like cyclosporin or methotrexate can be given, which can reduces the lymphocyte induced response. Now 11th transfusion reaction is hemosiderosis. The name itself suggests you will have the iron accumulation. You know, the 1 unit of red blood cell will contain the 200 microgram of iron. So if the patient is thalassemia or the patient is having aplastic anemia, then such type of patient need a repeated transfusion at the 15 to 20 days, right? Or at the monthly. So because of repeated blood transfusion, because of chronic red blood cell transfusion, they will have the iron accumulation in their body. Particularly first it will get deposit in the reticuloendothelial cells, and then gradually the iron will starting accumulating in the parenchymal cells. And the organs involved by the iron accumulations are heart, liver, and the endocrine glands. So the heart, liver, and the endocrine glands are at a more prone for iron accumulation. So these three organs will have the iron accumulation within their parenchymal cells, and because of iron accumulation these three organ function will be hampered. So how will you treat the hemosiderosis? Here you will have the iron accumulation. So for the treatment, you can give a agent that will chelate the iron. So iron chelating agents like dysferrioxamine can be given subcutaneously to treat a hemosiderosis. And how can you prevent the hemosiderosis? So the second option for prevention is that you can give transfusion of young red blood cell, which is known by the name neocytes. So the young red blood cell is having the more longevity, right? So it will reduces your transfusion requirement. The transfusion interval will be prolonged, right? You will not need repeated transfusion at every 10 days, right? Instead you might need it every 1 month. So it will prolong your transfusion interval, and so you will have the long survival of red blood cell because the young RBC will survive more, and because of long survival you will have the long transfusion interval, and so you will have the low iron accumulation. So that is the another option for the prevention of hemosiderosis. All right. The 12th adverse transfusion reaction is TTI, that is transfusion transmitted disease, and this is the very major risk of every blood transfusion. This is the main danger behind the transfusion reaction. See guys, sorry, the blood transfusion is not totally safe. Although the many blood banks nowadays using a very high, very specialized technique for detection of the transfusion transmitted diseases, right? But still you have a little chance that you might acquire transfusion transmitted illness because of the window period in which the antibodies or antigen cannot be detected by serological test. But for the prevention of such transfusion transmitted illness, every blood bank should necessarily screen the five main disease before the blood transfusion. So the blood should be screened for five main disease that can transmitted by the blood transfusion. That five disease include hepatitis B, hepatitis C, then syphilis, malaria, and the HIV 1 and 2. These five diseases should be screened by proper ELISA test at least to prevent the transfusion transmitted illness. So this is all about the transfusion reactions following the blood transfusion. These all are the adverse event. Hope you have enjoyed the video, and I will back with a new video. Sorry for such a long video, but to cover the whole topic I need to explain it in a detail. Thank you very much, and I will be back with a new video. Thank you very much. Take care and bye bye.